Hi everyone, good morning. Good morning, Shailesh Kumar Jha. I hope all of you are doing well and everything is fine at your end. Uh, with the FMG examination that is coming soon, I'm sure that most of you are a little bit tensed, a little bit worried about how you're going to perform in the examination. Trust me, that fear is going to push you to a longer way. You must have certain amount of apprehension, but not to an extent that you completely drown under it. You need to know to have a balance between, not being over or overtly confident versus being completely depressed about what you're going to do. So just a little bit of fear will keep you grounded, will push you hard to prepare well. So it's okay. Just accept it, saying that it's a part of your preparation and I'm going to do well in my examination. It's okay if I haven't studied something. It's okay if I have missed out on something, but I have studied so many things and I'm hopeful that the questions that come in the examination are going to come from what I have studied. So that will give you a positive mindset, that will give you a positive outlook for life and positive aura when you go around to the examination hall. So with this, I welcome you all to this session, and I am Dr. Vyshnavi, your ENT faculty, and today we are going to do some questions for FMG students. These are, of course, from the very important topics that I feel are for your examination, because without going through the important topics, it's going to be a waste to do any session at this moment of time for the FMG students. So today we will be doing only the important high yield topics, although I can't cover completely end to end in an hour, but maximum important questions I will be doing in today's class. So without wasting any of your time further, let's begin the class. A 12-year-old child presents to you with complaints of hearing loss. There is no prior history of ear discharge or pain or any surgery. On examination, the appearance of the tympanic membrane is as follows. What is your diagnosis? Is it congenital cholesteatoma? Is it otosclerosis? Is it glomus jugulaire, or is it acquired cholesteatoma? Yes, I'm waiting for your answers. So you see there is a whitish mass behind an intact tympanic membrane. What does this whitish mass say? So whitish mass behind an intact tympanic membrane. No history of prior otorrhea, no history of any prior ear disease, no history of any prior ear surgery, no history of any otological issues, as nothing. So what is this suggestive to you of? All this criteria is suggestive to you by a name which is called as Levinson's criteria for congenital cholesteatoma. So when you see a whitish mass behind an intact tympanic membrane, you must think about congenital cholesteatoma. But looking at the age, some of you might think that, ma'am, congenital, why is it presenting at 12 years of age? Cholesteatoma is a slow growing condition. It will not present to you suddenly. Only it will present to you very slowly, and over a period of time it will grow in the middle year, and usually between the age of 8 to 12 it will present. So 12 years complaining of hearing loss with whitish mass, no prior history of any diseases, typically suggestive to you of congenital cholesteatoma. Now, otosclerosis will have a sign where you see a flamingo pink appearance of the promontory through an intact tympanic membrane. That sign is called as Schwartz sign. In glomus jugulaire, when you see through the tympanic membrane, you will see a appearance which is called as rising sun appearance. And in acquired cholesteatoma, you will see that there is a perforation or a retraction in the pars flaccida. So there is a perforation or retraction of pars flaccida. So these are important tympanic membrane findings that you should know for sure in patients with ear diseases. So I hope everyone's got it. Good, Shailesh, and you've answered it right. Yogesh, you're wrong. It's not D. The answer is congenital cholesteatoma. Okay, let's go to the second question. What is the role of this procedure in a patient with cholesteatoma? So they're doing a procedure where they have kept a Siegel's pneumatic speculum in the ear, and they are trying to increase and decrease the pressure by inflating and deflating the cuff. Now, in a patient with cholesteatoma, what is the use of this procedure? This procedure is also called as Siegelization. So what is the use of Siegelization in a patient with cholesteatoma? Why do you want to do that? Okay, so some of you are saying B, Lakshmi is saying D. Okay, Yogesh is also saying D. Yes. So the correct answer is D. So basically, we are putting the seagull's pneumatic speculum in the external auditory canal. And whenever we think there is a patient who has a cholesteatoma, we know cholesteatoma has a propensity to go and erode the lateral semicircular canal. So it will go and erode the lateral semicircular canal. Now, whenever you increase the pressure in the external auditory canal, the pressure will go to the middle ear. But normally there is no transmission of pressure from the middle ear to the inner ear. But in patients with cholesteatoma, because there is a communication between the middle ear and inner ear, the pressure now gets transmitted to the inner ear, to the lateral semicircular canal, to cause vertigo and nystagmus. So this test in a patient with cholesteatoma is done to understand if there is any fistula or a communication between the middle ear and the inner ear. So the role of seagulization in a patient with cholesteatoma is to perform a fistula test. Good morning, Dr. Mithu Kumar. Let's see the next question. You see there is a device that is kept over here. What is this device and it is used in what conditions? So can you tell me what is this device and when do we use it? Yes, I'm waiting for your answers in the chat box. This device is a ventilating device that helps in ventilating the middle ear. This device is called as a grome. It is used in glue ear, ASOM, both A and B, none of the above. BKD says 1. What about others? Yes, so we know that grome is used only in glue ear. If the question would have been myringotomy is a procedure where you make a opening in the tympanic membrane. So myringotomy is done for ASOM and SOM. But grove insertion is done only in SOM, also called as glue ear, which is also called as non-suppurative otitis media, also called as otitis media with effusion. So whenever we think about glue ear, then the role of grome comes. But if you're thinking of making a hole in the tympanic membrane, of course, it is done for both the conditions, ASOM and SOM. So that's right. All of you got it right. Now let's go to the next question. Olfactory cleft lies between which two structures? Middle turbinate and the cribriform plate, superior turbinate and the cribriform plate, superior turbinate and the inferior turbinate and the cribriform plate. So where do you get olfactory cleft and the olfactory epithelium in the nose? We all know that this is present in the roof of the nose, olfactory cleft. Now where exactly in the roof of the nose is what you have to identify. Yes, I'm waiting for your answers. Some of you are saying B. Lakshmi says B. What about others? Love Pandey says C. Yes, so if I show you the olfactory cleft, it is present in the roof of the nose. So if you see here, olfactory cleft is present in the roof of the nose. Now the turbinate that you see here, this is going to be your superior turbinate. This is your middle turbinate and this is your inferior turbinate. Medially, we have got the septum. So what do we have medially? We have the septum. In the lateral wall, you are seeing three projections. What are these projections? Superior turbinate, middle turbinate, and inferior turbinate. So this is your superior turbinate. This is your middle turbinate. And this is your inferior turbinate. Now here in the roof of the nose, there is a thin plate of bone. This thin plate of bone is called as cribriform plate. So this space bounded by cribriform plate superiorly, septum medially and the superior turbinate laterally. This space is called as olfactory cleft. So it is a space bounded by cribriform plate superiorly, superior turbinate laterally and the septum medially. So it is present between the superior turbinate, septum and the cribriform plate. So the correct answer is going to be the superior turbinate and the cribriform. So I hope everyone got the answer to this question. If I have to draw it again for all of you, this is going to be your septum. This is superior turbinate, this is middle turbinate, and this is your inferior turbinate in the lateral wall of the nose. And here we have got the cribriform plate of the ethmoid like this. So what space we see here between the septum medially, superior turbinate laterally, and the cribriform plate superiorly. This space is called as olfactory cleft containing olfactory epithelium. Okay, so great. Now let's go to the next question. With regard to epistaxis, which of the following statements is true? It is most commonly idiopathic in origin. It is most commonly seen in children and middle-aged people. It commonly originates from Little's area in the posterior aspect of the nasal septum. It can be a cause of severe shock. So which of the following statement is true is the question. I'm waiting for your answer. Shailesh Kumar Jha, Little's area, is it present in the posterior aspect of the nasal septum or anterior inferior part? So this is clearly not the answer. This is not a true statement. Is it commonly seen in children and middle-aged people, or most commonly seen in children as compared to middle-aged people and adults? It is most commonly seen in children only, not in middle-aged people. Is it mostly idiopathic or traumatic in origin? It is most commonly traumatic in origin. But can it be a cause of severe shock? Yes, epistaxis can be a cause of severe shock. It is not uncommon that it can cause shock. It is a cause of severe shock. Okay. So the true statement is it can be a cause of severe shock. Fine, that was simple question. Now let us go to the next question, which is again very simple but commonly a repeat in the examination. True about this condition. Acne rosacea, most common in diabetics, most common in alcoholics, pre-malignant condition. So we can make this question as which is not true or false about this condition, because more than one options are true here. So what is this? This is called as rhinophyma. Rhinophyma is a condition where there is hypertrophy of the sebaceous glands following acne rosacea, seen in elderly and diabetics, seen in alcoholics. But is it a pre-malignant condition? No, it is not a pre-malignant condition. That is why the answer is not a pre-malignant condition. Yes, also called as potato nose. Again, a very simple, easy peasy question for all of you. Which of these anomalies is not related to choanal atresia? Cardiac valvular defects, mental retardation, renal agenesis, genital hypoplasia in males, ear deformities, including deafness. So, which of these anomalies is not related with choanal atresia? So, you should know choanal atresia is associated with a syndrome called as Charge syndrome. What does Charge syndrome stand for? What is C? What is H? What is A? What is R? What is G? And what is E? If you know this, you will be able to answer. C stands for Coloboma iridis. H stands for heart defects. A stands for atresia. The atresia is called as choanal atresia. R stands for retardation. It can be growth retardation. It can be mental retardation. G stands for genital abnormalities. And E stands for ear abnormalities. So which is not related, we see that renal is not a part of Charge syndrome. R is for retardation. It is not renal. Genital malformations is different from renal malformations. Genital in the form of hypospadias are seen, but you don't see renal agenesis in Charge syndrome. All of you have answered it absolutely right. So the anomaly is not related to choanal atresia, is going to be your renal agenesis. Many a time students get confused with E as well. E is for ear abnormalities. It is not esophageal. So if they would have given you esophageal, even that would not be related to choanal atresia. So don't make a mistake of that in your examination. Okay. Septal perforation may be seen in all except tuberculosis, syphilis, leprosy, toxoplasmosis. Again, a very simple question, but a repeat MCQ that you see very commonly in your exams. Again and again, we have seen questions on septal perforation. So you can see that there is a hole in the septum communicating the right nasal cavity from that of the left nasal cavity. So septal perforation occurs secondary to all except. So tuberculosis, syphilis, leprosy, all are known to cause septal perforation. The answer is toxoplasmosis. So toxoplasmosis does not cause any form of septal disease or any form of septal perforation. Now, amongst the options given, all of them will affect the cartilaginous portion of the septum except syphilis, where you get the bony perforation. Tuberculosis will involve the cartilage, leprosy will involve the cartilage. The bony septum is involved in syphilis. Total septal perforation is seen in vaginous granulomatosis. So these are all important one-liners which you cannot go to examination without learning. So bony septal perforation, syphilis, total septal perforation, vaginous granulomatosis. Okay, so this is about septal perforation. Okay, now let's go to the next question. Which of the following statements is true regarding this condition? They arise from within the nose. They usually appear unilaterally from one nostril only. They can be treated with steroid nasal spray. They require surgical intervention. So which statement is true regarding this condition? Yes. So I'll give you a clue. This is a mass originating from the maxillary sinus and it goes into the nasal cavity and then from there it goes to the choana. So what is this mass that I'm talking to you about? Coming from the maxillary sinus, going into the nasal cavity, from there into the choana. What is this mass? This is nothing but your antrochoanal polyp. So antrochoanal polyp, they do not arise from the nose. Where do they arise from? They arise from the maxillary sinus. So this is false. They arise from the maxillary sinus. They usually appear unilaterally from one nostril only. This is a true statement. Can they be treated with steroid nasal spray? No, because the cause of AC polyp is infection. It is not allergy that they require steroid nasal spray. But do they require surgical intervention? Yes. So these are the two correct statements that you should know regarding antrochoanal polyp. Now, just to differentiate antrochoanal polyp and ethmoidal polyp for a revision before your examination, let's do this. In which age group do you see antrochoanal polyp? It is typically seen in younger age group, but ethmoidal polyp typically in middle age and older age group. What is the etiology for AC polyp? The etiology for AC polyp is infection, whereas the etiology for ethmoidal polyp is allergy. Now, AC polyp is single and unilateral polyp originating from the maxillary sinus. And it grows it grows posteriorly towards the choana. Whereas ethmoidal polyp is multiple, it is bilateral, originating from the ethmoidal air cells, and they grow anteriorly towards the nasal vestibule. There is no role of medical therapy for AC polyp, but medical therapy is given for ethmoidal polyp. Surgical treatment is the treatment of choice where you do the functional endoscopic sinus surgery, and ethmoidal polyp also you will do FES because they are known to cause nasal obstruction and other symptoms. Recurrence is less in antrochoanal polyp, but recurrence is high in ethmoidal polyp. So this is quick one chart revision for you before your examination. So I hope all of you got this. If yes, let's go to the next question. Extraction of which tooth is commonly leading to a oroantral fistula? So we know the floor of the maxillary sinus is in relation to two tooth. Which are those two tooth? An extraction of these tooth will result in a communication to cause oroantral fistula. Yes, which tooth? The teeth that are in proximity to that of the maxillary sinus is second premolar and first molar. So whenever you extract the second premolar or the first molar, you must make sure that there is no communication between the maxillary sinus and the oral cavity, and you have to be very careful in extraction. So second premolar and first molar, both of them are responsible for causing oroantral fistula. The first premolar and second molar is not the answer. So you can see here the roots of the second premolar and first molar are in close proximity to the maxillary sinus. Good morning, Prakhar Tiwari. Radiotherapy in a case of JNA is indicated in all the following except intracranial involvement, primary modality of therapy, supply from the internal carotid artery, unresectable disease. So when is radiotherapy indicated in a case of following except? So all are indications except one. So in this question, you're learning what are the indications for radiotherapy in a patient with JNA. I'm waiting for your answers. This is very simple question. For juvenile nasopharyngeal angiofibroma, the treatment of choice is going to be embolization followed by surgical excision. So what is the primary treatment of choice? It is going to be embolization followed by surgical excision. So can radiotherapy be the treatment of choice or primary modality of treatment? No. But if there is a patient who has a JNA with intracranial involvement, supply from ICA and an unresectable disease, then you cannot do surgery. In that patient, surgery will not be feasible. Then they are inoperable. So if it is inoperable, then what is the other treatment of choice that we have for these patients? Since they are inoperable tumors, radiation is given to stop the further spread of the disease. Of course, they cannot cure the lesion, but they will prevent the further spread. So the treatment in a patient with JNA who requires radiotherapy, the indication is intracranial involvement, supply from the ICA, or if it is an unresectable disease. So I hope everyone got this. Great. This is again a common question that you get in exam. Radiation of pain to the ear in tonsillitis is along. They ask you any questions from referred otalgia. So you should know referred otalgia and what are the nerves responsible for causing referred otalgia. The radiation of the pain to the ear in tonsillitis is along which nerve? 10th nerve, 11th nerve, 7th nerve, or the 9th nerve. So you should know the nerve supply of the oropharynx. Then you will be able to know. So oropharynx is supplied by glossopharyngeal nerve. Glossopharyngeal nerve gives a branch in the middle ear which is called as tympanic branch of glossopharyngeal nerve. This tympanic branch of glossopharyngeal nerve is called as Jacobson's nerve. And this Jacobson's nerve is responsible for causing radiation of pain to the ear. So the nerve that is responsible is going to be your glossopharyngeal nerve. Now just to reiterate with all of you about the nerve supply and the referred otalgia, if they ask you any questions from referred otalgia and what nerve is responsible, you should know the answer. So first of all, if they give you any lesion in the anterior two-thirds of the tongue, the anterior two-thirds of the tongue is supplied by the lingual nerve, and this is a branch of the trigeminal nerve. So the nerve that is responsible for causing referred otalgia from the anterior two-thirds is the trigeminal nerve. So if they tell you there is a lesion at the lateral border of the tongue, in the tip of the tongue, what nerve is causing referred otalgia? The answer will be fifth. Any lesion in the posterior one-third of the tongue, the oropharynx, in this entire area, it is going to be glossopharyngeal nerve. Now coming to the larynx and the hypopharynx, this area, the nerve that is supplying is the vagus nerve. So referred otalgia from larynx and pharynx lesion will be via the vagus nerve. So now I think you're clear on referred otalgia and which areas cause referred otalgia. If you know this, you should be getting all the questions related to referred otalgia in your exam. Even from cervical spine C2, C3, you have got the You have the nerves, lesser occipital nerve supplying the pinna, so you can have referotalgia from C2, C3 as well. But that's a rare question. These three are something that you should know for your examination. Okay. Cardiac condition secondary to hypertrophic tonsil and adenoid is called as for pulmonale, AST, bundle branch block, or VST. So, which is this cardiac condition secondary to hypertrophic tonsil and adenoid? Yes, I'm waiting for your answers. Yes, very good, Dakshineshwar. Very good, Yogesh. So, whenever we have got a hypertrophic tonsil, because the tonsil is connected via the Waldeus rings to the adenoid, you will see there is a hypertrophy of the adenoid as well. So, most often tonsillar hypertrophy is associated with an adenoid hypertrophy as well. So, if there is a adenoid hypertrophy, can the patient breathe well? Can the patient breathe from the mouth? No. Now, when the patient sleeps, will the tongue collapse back and further block the airway? Yes. So, what happens especially in sleep? What will happen is the patient will have obstruction in the upper airway resulting in sleep apnea. So, what will happen? There is obstructive sleep apnea. Now, when there is an obstructive sleep apnea, the child will have a chronic hypoxia because every night the child is sleeping, tongue is falling back, not able to breathe from mouth, not able to breathe from nose. Chronically, there will be hypoxia. Now, when there is a chronic hypoxia, what will happen to the pulmonary pressures? Sorry, the pressures in the heart, the pulmonary artery, there will be hypertension. Now, retrograde, what will happen to the pressure in the right ventricle because the pulmonary artery is having extreme pressure to gain the oxygen from the lungs? You will see that retrograde behind you will have the right ventricular hypertrophy. So this condition where you have got pulmonary artery hypertension and a right ventricular hypertrophy, we call this condition as cor pulmonale. So I hope everyone's clear what is cor pulmonale. This is a condition that you see secondary to hypertrophic tonsil and edema. Okay, let's go to the next question. Schwartz operation is myringotomy, cortical mastoidectomy, modified radical mastoidectomy, facial nerve decompression. Now we are talking about Schwartz operation, not about Schwartz sign. Schwartz sign, I have already told you what it is in the first slide itself. We discussed that Schwartz sign is flamingo pink appearance of the promontory seen through an intact tympanic membrane in patients with otosclerosis. So that we saw is in otosclerosis. Now we're talking about Schwartz operation. So where do you do a Schwartz operation or what is it? It is synonymous with what? Very good, Mithu Kumar. I'm waiting for others to answer. Yes, very good. So Schwartz operation is nothing but your cortical mastoidectomy. So Schwartz operation is cortical mastoidectomy. So first of all, what is the meaning of cortical mastoidectomy? We have the mastoid which communicates to the middle ear via the adductus. We have the largest air cell called as the antrum, and then we have got numerous other mastoid air cells. Now, if we open the antrum and if we open all the other mastoid air cells, see, we are opening up the antrum, we are opening up all the mastoid air cells via surgery. And now what are we doing now? We are establishing a communication with a single mastoid cavity to that of the middle ear. This surgery is called as cortical mastoidectomy. So what is cortical mastoidectomy? It is exentration of all mastoid air cells. So you are opening up all the mastoid air cells and communicating them to what? Communicating them to the middle ear. Now here the wall between the mastoid and the middle ear is intact. So this wall is your posterior wall. This is intact. That is why this cortical mastoidectomy is also called as intact canal wall mastoidectomy. But if we have to do a procedure where we will have to take away this posterior canal wall and now convert the entire mastoid, middle ear and the external auditory canal into one single cavity. So the external auditory canal, mastoid and the middle ear into one single cavity. You have removed that posterior wall of the middle ear. You have removed this. This surgery we call it as modified radical mastoidectomy. This is called as modified radical mastoidectomy. Modified radical mastoidectomy is also called as canal wall down surgery. This is also called as canal wall down. So these are the two common surgeries. Canal wall up or intact canal wall is cortical. Canal wall down is modified radical. Cortical is also called as Schwartz operation. So clear to everyone? Okay, so now you're having a clinical image given to you. Which of the following are the two most important tools in the diagnosis of this condition? You see there is a hole in the or a perforation in the pars flaccida. What are the two important tools that are responsible or useful in diagnosing the condition? So first of all, whenever you get a perforation in a pars flaccida, will you think of a safe disease or an unsafe disease? What will you think of? So whenever we get a perforation in the pars flaccida, we are thinking about an unsafe type of a CSOM. Sometimes it can be associated with a cholesteatoma. So should you do otoscopy and radiographic examination? Of course, otoscopy will give you the finding. History and culture data, is it going to be useful? Of course not. There is has some use, but is it going to give us the diagnosis? No. Audiometry and otoscopy, yes, it is going to give us some information about the ossicular status, the amount of hearing loss, the perforation and the pars flaccida, yes. Radiography and audiometry. Radiography will definitely tell you that there is any cholesteatoma in the middle ear, erosion of the tegmen, erosion of the ossicles, erosion of the canal, lateral semicircular canal, it will tell you. Physical examination and patient demographics will not tell you. So now we are left with option where we have otoscopy and radiography, audiometry and otoscopy, radiography and audiometry. Now, if we take amongst all these investigations, will audiometry tell us specifically it is a safe disease, unsafe disease, or whatever related to CSOM or cholesteatoma? No, audiometry will tell us hearing loss. Now, hearing loss can be because of innumerable causes, can be because of wax, can be because of SOM, it can be because of tubotympanic type of CSOM, it can be because of eticoantral type, it can be because of cholesteatoma. Audiometry, my answer will give you conductive hearing loss. Now, can it tell you this is due to cholesteatoma or due to unsafe type of CSOM? No. So that is why audiometry will go out of question now. I mean, of course, you will do audiometry as an associated diagnostic tool, but it will not tell you the diagnosis. So what is telling you the diagnosis? The answer is otoscopy, because otoscopy is showing to you there is a perforation which is suggestive to you of unsafe disease. Radiographic examination is telling to you the extent and spread of the disease. The two most critical tools for diagnosing an unsafe type of CSOM is otoscopy and radiographic imaging. So very good, Rushikesh, Deepak and Jaydev Das. All of you are absolutely right. So the correct answer is otoscopy and radiographic imaging. Okay, let's go to the next question. Vertigo and nystagmus in a setting of cholesteatoma are concerning which of the following? Labyrinthine fistula, meningitis, brain abscess, or sigmoid sinus thrombosis. So if there is a patient with cholesteatoma who has vertigo and nystagmus, which of the following is true? Does it indicate labyrinthine fistula, meningitis, brain abscess, or sigmoid sinus thrombosis? So if I take this as the middle ear, this is your inner ear where we have the lateral canal, superior canal, and the posterior canal, and this is your cochlea. So if there is a cholesteatoma in the middle ear, we know the cholesteatoma has a propensity to erode. And when it erodes, it will go and erode the lateral semicircular canal. And now when the lateral semicircular canal is eroded, what can happen? The patient will have vertigo, the patient will have nystagmus. So in a patient who has cholesteatoma, the presence of vertigo and nystagmus is suggestive to you of a labyrinthine fistula. Very, all of you are right. Mukesh, Mittu, Zevi, Rushikesh, Lakshmi, Deepak, Shailesh Kumar. Very good. The answer is labyrinthine fistula. Now I have again discussed this question in the first slide itself, but again for your practice, we will do it. A patient presents with bleeding from the ear. So the symptom is that of bleeding. There is ear pain, tinnitus, and progressive deafness that is associated. So there is pain, tinnitus, and deafness. On examination, you see there is a red swelling behind an intact tympanic membrane. This reflex, we call it as rising sun appearance. Now, on increasing the pressure in the external auditory canal, the mass initially is red, vibrates vigorously, and then becomes pale. So what is your diagnosis on this history? So your diagnosis, I'm sure everyone knows, this is nothing but your glomus tumor. So what is the management of this patient, or all except? So you will manage this patient with radiotherapy, surgery, interferon, or preoperative embolization. So all are used in the treatment except one. What is it? The treatment of choice for glomus tumor is again like your JNA, where you do surgery before after embolization. So you will do an embolization, preoperative embolization, followed by surgical excision. So definitely these two are done for the JNA. This is the treatment part. Radiotherapy is given if it is inoperable tumor, but do we have role of interferons in patients with glomus tumors? No. So in glomus tumors, we don't have role of interferon. So you have the role of surgery, embolization, and radiotherapy if the tumor is inoperable, but there is no role of interferons, or primary role of interferons in the treatment for glomus tumors. The sign we have already told, we call it as rising sun appearance. And the sign where it blanches on pressure, we call that sign as brown sign. So these are the signs that you see in glomus. So I hope you have got it right about glomus tumor, everyone. Fine. So let's go to the next question. With regards to Meniere's disease, the following statements are true. Typically presents to you between the age of 30 to 50 years. It's characterized by hyperacusis, vertigo, and tinnitus. Audiometry will show you conductive hearing loss. Treatment most effective is lifestyle changes such as low salt diet, thiazide diuretic. So with regard to Meniere's disease, which of the following is true? Which statement is true? I'm waiting for your answers. So with regards to Meniere's disease, which of the following statement is true? Very simple question. We know Meniere's disease is characterized by a triad. So what is the triad of Meniere's? It is vertigo, sensory neural hearing loss, and tinnitus. But here they have given hyperacusis. So is this true? All of you who have told true? Mukesh, Sachin, Shailesh, Naira, Mithu, Deepak, is this true? They have given hyperacusis. Is this true? So can this statement be true or false? All of you said too nicely, right? This is going to be a false statement because there is not hyperacusis. Patients have hearing loss. They do not have an increased sensitivity to sounds. In fact, they are able to hear lesser. So they have a hearing loss. So that statement is false. Now, audiometry will show you conductive hearing loss or sensory neural hearing loss. Audiometry will tell you sensory neural hearing loss. So this statement is also false. Treatment is treatment most effective is lifestyle changes such as low salt diet, thiazide diuretic. Is this the most effective? No, this is only for preventing the episodes. But intratympanic steroids, ITS, is the treatment of choice. So this is also false. But can it present to you between 30 to 50 years of age? Yes. So this statement is your true state. Now everyone got it? Most of you had answered this B, looking at vertigo, tinnitus, and you thought that is the right answer. Don't get tricked in the exam. The examiner's work is to trick you. He's sitting there for the very purpose that I'll put some trick here and the student will get confused and fall in my trap. But you are going to be intelligent than your examiner and tell him, hello, you put a trap. I am very sensible. I am not going to fall in your trap. So look for these traps in your examination. सबको आता है, सब लोग कर सकते हो. उतना ही है कि प्रेजेंस ऑफ माइंड रखो, भरोसा रखो अपने आप पे कि मैं कर सकता हूँ, एंड यू गो टू द एग्जाम हॉल विद पॉजिटिव कॉन्फिडेंस, विद फुल वाइब एंड टशन. You will do very well. Okay, let's go to the next question. The diagnostic test for confirming Meniere's disease is history and clinical examination, glycerol test, electrocochleography, high resolution CT scan of the temporal bone. So which is the diagnostic test? Which is the investigation of choice for patients with Meniere's disease? See, there is an investigation that measures the pressure inside the cochlea. So what is that test that measures the pressure inside the cochlea? That test is called as electrocochleography. Normally on electrocochleography, SP by AP, summation potential to action potential. SP is summating potential. AP stands for action potential. So summating potential to action potential, normally the ratio is less than 30% or 0.3. Then it is normal. But if it is more than 30% or 0.3, it is suggestive to you of Meniere's disease. So the investigation of choice for diagnosing Meniere's disease is electrocochleography. Of course, history is diagnostic. We will know with history, but will it tell you the pressure inside the ear? It cannot. Glycerol test पे पता चलेगा कि the improvement in audiometric scores after giving glycerols? Yes. But now, do we have a test that will directly tell us the pressure inside the inner ear and the cochlea? Yes, so we will have that as the investigation of choice, which is electrocochleography. Very good, all of you. With regard to labyrinthitis, the following is true except it may be a complication of URTI, it may cause hearing loss, there is nystagmus towards the unaffected ear, vestibular suppressants are used in the treatment. It can be caused by virus or bacteria. So all of them are true except. So labyrinthitis is a condition where there is inflammation of the labyrinth. Labyrinth has got the cochlea, it has got the vestibule, and it has got the semicircular canal. So if there is inflammation of the labyrinth, can it cause hearing loss? Yes. Can it cause vertigo? Yes. And hence, will you use vestibular suppressants? Yes. Can it follow an URTI? Yes. Can it cause this URTI be caused because of bacterial infection or viral infection? True. So all of this is true. But what is not true? Nystagmus towards the unaffected ear. Now, labyrinthitis has got three different forms, but the most common form of labyrinthitis, you see the labyrinth is hyperactive. So one labyrinth is hyperactive, the other labyrinth is normal. So if one ear is having hyperactive labyrinth, the other ear is normal. Where will the eyes get deviated? Normally, the eyes are being pulled towards each labyrinth. Like right ear, right labyrinth is trying to pull the eye towards the right side, left labyrinth is trying to pull the eye towards the left side. So our eye is going to be in the midline position. But if the right labyrinth becomes hyperactive, where will the nystagmus be? Will it be towards the affected side? Yes. So here the nystagmus is not not towards the unaffected ear, it is towards the diseased ear, because the diseased ear is usually hyperactive. So did everybody get the concept of why in hyperactive lesions the nystagmus is towards the disease side? And if this, and if we take this is a hypoactive labyrinth, where will the nystagmus be? Hypo on one side, normal on another side. Where will the nystagmus be? Normal has more power, so the nystagmus will be towards the opposite side. Got it? Yes. So that was about labyrinthitis. Now let's go towards the next question. With regards to BPPV, the following statements are false. It may present to you with severe vertigo facing a certain direction. Symptoms can be elicited by a Dix-Hallpike maneuver. It can be caused by the presence of otolith moving within the vestibule. It may be treated by a Please maneuver. So one statement is false. What is that false statement? Yes, I'm waiting for all of you to answer. Benign paroxysmal positional vertigo is a very common question in your examination. See, which statement is false is the question, okay? So Jaydev, Pranav, Abhishek Mishra and Mithu Kumar, in BPPV, what is happening? We have got small crystals of calcium carbonate which are present in the ampulated end of the semicircular canal where they open in the utricle. These are called as otolith. So these otolith are small crystals of calcium carbonate. They should be present in this area where the semicircular canal opens in the utricle. They should be inside the area of the utricle. Now, if the otolith get displaced and enters into the semicircular canal duct, what will happen? The canal gets stimulated, resulting in vertigo. Now, this in the name only you have is positional vertigo. When the patient puts his head in certain position, the otolith will get displaced to cause vertigo. So the first statement that severe vertigo in a head facing to certain direction is absolutely true. What is Dix-Hallpike maneuver? I will do a test where I'll put the patient in a certain position to elicit vertigo and nystagmus. That is called as a Dix-Hallpike maneuver. This is the diagnostic test for BPPV. So can symptoms be elicited by Dix-Hallpike maneuver? Yes, it is diagnostic. Now, once we know on diagnostic test that it is BPPV, how do we treat BPPV? It is treated by a Please maneuver. So these three statements are true. What is not true? It is caused by presence of otolith moving within the vestibule or moving within the semicircular canal duct. So please see the trap here. The word is not vestibule. The answer should have been semicircular canal duct. So this is the false statement. The most common canal that is involved in BPPV is going to be your posterior semicircular canal. Okay. So I hope everyone got this now. Many of you made a mistake in the beginning. So now I think you know how to answer such questions. Okay. A 55-year-old male with uncontrolled diabetes presents with severe ear pain and discharge from the ear. Otoscopic finding is shown below. What is the nerve that is most often going to be involved in this condition? Fifth nerve, seventh nerve, ninth nerve, or the sixth nerve? So you're seeing there is a granulation tissue in the external auditory canal. This is caused by Pseudomonas. So what is your diagnosis? Pseudomonal infection in the external auditory canal. Do we call it as malignant otitis externa? So malignant otitis externa is a condition where there is inflammation of the external auditory canal because of Pseudomonas, usually seen in elderly and diabetics, and the nerve that is often going to be involved is going to be the seventh nerve. So the nerve that is most often going to be involved in this condition is going to be your seventh nerve. First, the nerve will be seventh nerve. Later, when the infection goes towards the base of the skull, then you can have ninth, 10th, 11th, and 12th. But the question is asked most often going to be involved. most often going to be involved is going to be your facial nerve, which is present near the posterior wall of your external auditory canal. So Shailesh, did you get the answer? Naira Sheikh, Dr. ZV, Yash, Mukesh Kumar, did you understand? Abhishek Mishra. So most often, which nerve is going to be involved? It is your facial nerve. Okay, what is true regarding this condition? So they have shown you that there is a vesicular rash. They are telling to there is a element type of facial palsy and loss of taste sensation towards the anterior two-thirds of the tongue. So what is true regarding this condition? It may present to you with facial palsy, hearing loss and vertigo. It can be differentiated from Bell's palsy by cutaneous vesicles in the ear canal. It is caused by adenovirus. It is treated with acyclovir and prednisolone. It has an excellent prognosis and 99% of the patients regain pre-morbid facial function. So what are we talking to you here when I show you this clinical image? What is your diagnosis? Yes, the diagnosis is going to be Ramsay-Hunt syndrome, also called as herpes zoster oticus. So if we are thinking about herpes zoster oticus, it is caused by herpes zoster virus, which is not an adenovirus. So is this a totally wrong option? We have ruled out. Now, can this be treated with antivirals? Yes, but is the role of steroid mandatory in herpes zoster oticus? No, we do not give steroid. We give steroid in Bell's palsy. In herpes zoster oticus, it is based upon the patient condition, weighing the risk and benefit. We do not give to all patients of Ramsay-Hunt syndrome like how we give for all patients with Bell's palsy. Does it have an excellent prognosis? No. Bell's palsy has an excellent prognosis. Ramsay-Hunt syndrome has a poor prognosis. Now, it is differentiated from Bell's palsy by presence of vesicles in the ear canal. Yes. So in Bell's palsy, we will have element type of facial palsy. In Ramsay-Hunt syndrome, also element type of facial palsy. But in Bell's palsy, you do not see vesicles. But in Ramsay-Hunt syndrome, you will see vesicles. So this is true. It may present to you with facial palsy, hearing loss and vertigo. It can definitely present to you with facial palsy with sensory neural hearing loss. But vertigo is not common manifestation of herpes zoster oticus. So vertigo is a rare manifestation. So this statement is a partially true statement. So if you have to choose one answer, you will choose only two. If you have to choose two answers in the examination, then you will choose one and two. Okay. So everybody got this question? Okay. In acoustic neuroma, which of the following is not seen? Sensory deficit, motor deficit, auditory deficit, changes in the audiometry. Which is not seen? Acoustic neuroma is a tumor originating from the vestibular nerve in the internal auditory meatus. So when it involves the seventh nerve and the eighth nerve and the fifth nerve, is it going to cause sensory deficit? Yes. If it is involving the eighth nerve auditory deficit, yes. And if there is an auditory deficit or a sensory neural hearing loss, will there be changes in audiometry? Yes. But will there be a motor paralysis? No, until there is a spread of the disease causing compression on the brainstem, causing compression, then you might have motor deficits, but most often you will not have any motor deficits. You will have sensory auditory deficits in acoustic neuroma. So the answer is going to be motor deficit. Okay, identify the lesion. Which of this following is true about the lesion? It is a cystic lesion in the floor of the mouth with transillumination test negative. When it pierces the hyoglossus, it is called as plunging type. Treatment involves excision of the cyst along with sublingual salivary gland and none of the above. So which of the following is true about this condition? A, B, C, or D? I'm waiting for your answers. Yes, of course, the diagnosis is that of a ranula. So it is a cystic swelling in the floor of the mouth with transillumination test negative or positive. Transillumination test is positive. So is this statement true or false? This is false. When it pierces the hyoglossus, we call plunging type, or when it pierces the mylohyoid muscle, we call it as plunging type. When it pierces the mylohyoid. So this is also false. Treatment is excision of the cyst along with the sublingual salivary gland. That is the true statement. The treatment of ranula is you have to excise the ranula along with the sublingual salivary gland. So the correct answer is going to be C. Okay. A 8-year-old child presents to your OPD with a sudden onset of pain below the chin since a day with gradually increasing, which is gradually increasing in size. On examination, there is trismus and there is a woody hard feeling. So there is something called as woody hard feeling, which is false regarding this condition. So you should know your diagnosis based on the clinical image, based on the word given here. What is your diagnosis? Starts with L and A. So L, A are the two words, first letters of the two words. So think about it. It's an infection of the submandibular space. The space is divided into two compartments by the mylohyoid. Alpha hemolytic streptococcus is the etiological agent. There is no risk to the airway and a patient can be sent home with antibiotics. So which statement is false? Yes, very good. Most of you have got the answer right. So this condition is called as Ludwig's angina, which is nothing but cellulitis of the floor of the mouth of the submandibular space. This space is divided into two compartments by the mylohyoid muscle. Alpha hemolytic streptococcus can be etiological agent with aerobes, anaerobes, mixed infection. There is a risk to airway. There is no risk is a wrong statement. There is a risk to airway and the patient cannot be sent to home. The patient has to be admitted, monitored for airway collapse because the tongue will fall backward causing airway obstruction and you will have to do a emergency tracheostomy. Okay, let's go to the next question. The boundaries to retropharyngeal space is all except. It lies between buccopharyngeal fascia and the prevertebral fascia. It is in the midline, contains lymph node, extends up to the level of T4. So if I take this as the vertebra is covered by a fascia called as the prevertebral fascia. So this is your prevertebral fascia. Anteriorly, we have the outermost layer of the pharynx, which is formed by the buccopharyngeal fascia. In the midline, there is a septum between the prevertebral fascia and the buccopharyngeal fascia. Now, the space that we have on either side of this septum, this space is called as your retropharyngeal space. So is the retropharyngeal space lying between the buccopharyngeal fascia and the prevertebral fascia? True. Is it in the midline or on either side of the midline? This statement is false. It is not a midline space. It is on the either side of the midline. It contains lymph node. These lymph nodes are called as node of Rouvier. So this is also true. Superiorly, it extends from the base of skull. Inferiorly, extends up to the fourth thoracic vertebra. This is all. So all of them are true. It is not a midline space. Midline space is only a single space, and that space is your prevertebral space. So the space that you have here between the prevertebral fascia and the body of vertebra here, this space is a single space across the midline. That space is your midline space, which is your prevertebral. Okay, so mostly everyone has got the right answer. So retropharyngeal space extends between the prevertebral fascia posteriorly and the buccopharyngeal fascia anteriorly. It's not a midline space. It's seen on the either side of the midline. Okay, a very easy, simple question for all of you. A male aged 60 years has foul breath. He regurgitates food that he has eaten 3 days ago. What is the likely diagnosis? Very simple. You would have read this 2000 times, 2 million times, 2 lakh times, and up to the moon and back. What is the diagnosis? Yes, very good. This is nothing but pharyngeal pouch, also called as Zenker's diverticulum. So this answer is pharyngeal pouch, also called as Zenker's diverticulum. Components of Trotter's triad are all except conductive deafness, temporoparietal neuralgia, palatal paralysis, retroorbital pain. This is a PYQ. Trotter's triad is seen in nasopharyngeal carcinoma. So what is the component of this triad? All three are there. One is not a component. Which is that component? Absolutely right. Naira, Lakshmi, ZV, very good. The answer is retroorbital pain is not a component. So Trotter's triad consists of conductive deafness, pain along the distribution of the trigeminal nerve, and palatal palsy. So conductive deafness plus involvement of fifth nerve and the 10th nerve. This triad we call it as Trotter's triad. Okay, this is again a very simple question. All the following are true about this condition except. So which statement is not true or which statement is false? It is a air-filled cystic swelling due to dilatation of ventricle. It can be of three varieties: internal, external, or mixed. It is seen in trumpet blowers, glass blowers, and weightlifters. Treatment involves excision through an external neck incision. So what all, if you see very closely, you will identify a mistake, but otherwise all the statements are absolutely right. One statement is partially wrong. What is that partially wrong statement? Very good, Jaydev. Dr. Z, we absolutely right. This is the answer. The diagnosis here is a laryngocele. You can see an air-filled swelling, cystic swelling on the side of the neck seen in trumpet blowers, grass blowers, weightlifters. Can be of internal, external, and mixed. And external one requires an external neck incision is true. But does this occur due to dilatation of ventricle? No. Let us understand. So we have the false chords above in the larynx and true chords below in the larynx. Now, there is a space between the false chords above and the true chord below. This space is called as ventricle of the larynx. From ventricle, you get an elongation. This elongation is called as saccule. So, laryngocele occurs due to dilatation of saccule, which is a part of the ventricle. So, that is why I said this statement is partially wrong. Okay, so the correct answer is at A, which is due to dilatation of vacuole. Okay, identify this. Which of the following is true regarding this condition? Causes inspiratory stridor. Stridor is relieved by lying the child in supine position when feeding. Stridor is worse on prone position. It is more common seen in younger children. Improves with as the child grows older. Now there are multiple correct answers over here. You can mention at least one. Okay, I'm waiting for your answers. So we are talking about laryngomalacia, which is the most common congenital anomaly of the larynx. It causes inspiratory stridor. Yes, that is true. Very good. Most of you are right. Stridor is made by putting the child in supine position and feeding is false. In the prone position, the stridor gets relieved, and also when the child is not feeding, feeding will worsen the stridor. Stridor worsens in prone position is false. It improves on prone position. It is common in infancy, not in young children. It is the child improves as they grow older. This is true. So 1 and 5 is true. Okay. Okay, a 32-year-old man, while laughing at the dinner table, begins to choke and starts to turn blue. You are beside him. Which of the following regarding initial management of this patient is true? The patient has swallowed a foreign body. Heimlich maneuver should be attempted. Heimlich maneuver involves 2 breaths and 1 chest compression. Obstruction of right bronchus is more dangerous than obstruction of the larynx. Patient will recover spontaneously and should not be approached. So which statement is true? You have to answer what is the true statement. Yes. So the correct answer is Heimlich maneuver should be attempted. The patient has swallowed the foreign body or inhaled. Inhaled is when it has gone into the respiratory tract. So that is why this statement is false. It has not swallowed, the patient has inhaled the foreign body. Heimlich maneuver involves holding the patient from behind and giving compressions on the xiphisternum and blows on the back. This is false. Obstruction of larynx is more dangerous than bronchus, because even if one bronchus is obstructed, you have the other bronchus and lung functioning to give ventilation. But if the larynx is obstructed, there is no ventilation. So laryngeal obstruction is more dangerous than right bronchus obstruction. The patient should be taken into task and should be given Heimlich's maneuver to displace the foreign body so that the patient can breathe. So the correct answer is only. So with this, I finish my session. I hope you guys enjoyed this quick session with me. I'll come back again to do more discussion with all of you. And if you've got any doubts, feel free to comment in the chat box. Feel free to join me on my Telegram or my Instagram for any of your doubt clearances. I will be there for all of you. So if you need to know anything more, let me know in the chat box. If not, we'll take a leave and say bye-bye. All the best, do well, study well, don't get distracted. It's the time where you need to have positive vibes, positive energy, and like I said, just breathe in, breathe out, sit with confidence, think with confidence. Automatically everything will fall in place. Don't fall to the fact that I have not studied something. It's not important that what you have not studied right now. What's important is how you're going to take forward your preparation to the amount of studies that you've already done. So just lean back, take rest, study well, eat well, and do the best in your exam. I'll see you again. Bye.